Hello everyone, welcome to this online section, Chemical and Physical Injury to the Eye. I'm Dr. Howie Chen from Joint Shantou International Eye Center, Shantou University and the Chinese University of Hong Kong. Today we will talk about chemical injury and several kinds of physical injuries to the eye. Among them, chemical injury is the most important. You are expected to describe the clinical manifestation, complications, and immediate management of chemical burns. Chemical burn is the number one ophthalmic emergency. This means that conjunctival washing should be performed immediately. The chemical may be alkali or acid. Alkali has a more penetrating effect than acid because acid can induce protein degeneration, and the coagulated protein will prevent further penetration. Alkali, on the other hand, induce saponification of ocular surface cells, which will secrete protein-lytic enzymes and cause further damage. The cornea epithelium is the first to be damaged. Then stroma edema and ulceration will follow. Some patients may develop full-thickness corneal perforation. In the late stage, corneal neovascularization is a common complication. Limbus may be hyperemic or ischemic, which appears red and white respectively. Ischemia is much more severe than hyperemia. The limbal stem cell may also be damaged. We can see hyperemia and chemosis in the conjunctiva. In the late stage, sybramphyllum and entropion may develop. Only the ocular surface has contact with the chemical, but the damage will penetrate into intraocular tissue in severe cases. There may be intraocular inflammation and secondary glaucoma. Ocular chemical injury can be graded into 4 levels according to the damage of cornea and the region of ischemia in the limbus. Grade 1 means that there are only corneal epithelium damage and no limbal ischemia. In Grade 2, we can find the corneal heads and the detail of the iris is still visible. The region of limbal ischemia is less than 1/3. The prognosis of Grade 1 and 2 are good. In Grade 3, there is total epithelium loss, stroma heads, and the detail of iris is obscured. The region of limbal ischemia is between 1/3 to 1/2. The prognosis of Grade 3 is guarded. While in Grade 4, the cornea is opaque. The iris and the pupil are obscured, and the region of limbal ischemia is more than 1/2. The prognosis is poor for Grade 4. The natural history of chemical injury can be divided into 4 stages. The immediate stage is within several minutes of exposure. The patient should receive irrigation right away with whatever water is available. Early irrigation is critical in limiting the duration of chemical exposure. The acute stage is from several minutes to 1 week, and the major problem is inflammation. Anti-inflammatory drugs, including corticosteroids, NSAIDs, and cycloplegia, should be instituted. Supportive therapy with artificial tears and growth factors would also benefit the hearing. The third stage is the early repair stage. It is from 1 to 3 weeks. The activity of collagenase is a major problem in this stage. Therefore, corticosteroids should not be used if there is a corneal epithelium defect. Surgical or medical treatment can promote epithelium recovery. The last stage is late repair, more than 3 weeks after exposure. The major problem is complication that need surgical intervention. Let's move on to photokeratitis. It is the damage of corneal epithelium by ultraviolet irradiation. The ox eye and snow blindness are both photokeratitis. In the epidemic of SARS and COVID-19, there is also increased incidence of photokeratitis because many people use UV germicidal lamps for disinfection. The symptoms typically occur 6 to 12 hours after exposure to UV light. The patient have bilateral eye pain, photophobia, tearing, and decreased vision. Slit lamp examination with fluorescence staining reveals diffuse corneal epithelium damage. Generally, the condition will recover within 24 to 72 hours. Topical anesthesia can relieve the symptoms but only last for 1 hour. Supporting therapies such as artificial tears would also alleviate the symptom. Solar maculopathy is caused by watching a solar eclipse without enough protection. The intense sunlight damages the fovea. There are only some pigment chains on fundoscope. With optical coherence tomography, we will find photoreceptor destruction, intraretinal cysts, and lamellar macular hole. There is no specific treatment for solar maculopathy. Radioactive retinopathy and optic neuropathy are complications of radiotherapy. The eye condition may occur several days to many years after radiotherapy. The pathogenesis is vascular endothelial cell apoptosis and ischemia. There are cotton wool spots on the retina, and fluorescence angiography can show non-perfused regions. The patient may develop complications of retinal neovascularization, vitreous hemorrhage, tractional retinal detachment, and neovascular glaucoma. The damaged blood vessel supplying the optic nerve will lead to ischemic optic neuropathy. There may be edema of the optic disc. If there is large non-perfused region on FFA, laser photocoagulation can be used to prevent complications. Let's summarize what we have talked about today. Chemical burn is the #1 ophthalmic emergency. Immediate irrigation is critical in management. There are 4 grades according to the range of limbal ischemia. This condition evolves through 4 stages, each of which is managed differently. Photokeratitis is the corneal epithelial damage caused by UV light. Solar maculopathy is the injury to the photoreceptors by sunlight. Radioactive retinopathy and optic neuropathy result from vascular endothelial apoptosis in the retina caused by radiotherapy. Thank you for joining us. This is the reference for your further reading.